Welcome back to Toledo Clinic TV. Our special guest for this segment is Mike DeRamo, and he is the Chief Administrative Officer. And you have seen a lot of changes in your career at the hospital side, at the doctor side, at the patient side. But I want to talk about the future of physician practices. How do you think things are going to be moving in the near future?
You know, I had the experience, I'm not sure it was a great experience, of telling an audience that this was my 35th year in healthcare. And I started off at Henry Ford Health System, which was one of the fathers of what they call integrated delivery in the current era. And that's where, again, the hospital, the physician, and the insurance entities all within this common parent. So in that 35 years, this is now, I believe, the third iteration of the employed physician. So you have to ask yourself, well, why do physicians keep going through this cycle of employment and disemployment and reemployment? And integrated delivery is part of that driver, is that large health systems feel that if they don't, quote, own the physician, then they can't own the process. And over the previous cycles in the 90s and the early part of this century, health systems would make distinctions. Gosh, I need to employ the primary care physician because that way the primary care doctor will refer. Or I need to, quote, own or employ the specialist because if I have those physicians, then I know my hospital will have adequate surgeries and admissions. And then probably this third iteration is, well, we have to have the whole thing. So you'll see different health systems have different strategies depending on the needs of that particular market and the needs of that particular hospital. So, but it's like any other bubble in any other economy where you'll see a very rapid growth of employment, and then you'll see the hospitals realize that they've reached a threshold that is not sustainable. And then they'll peel off all or some of those physicians that had been previously employed. I think what you're going to see, and we're starting to see nationally, is kind of a hybrid model. So the old way was, welcome to the team, you're now an employed physician, here's your badge, good luck and Godspeed. And more and more of how insurance and patient care is being rendered requires a much more symbiotic relationship between hospital and doctor. And it requires really doctors to do a lot more than they used to 20 years ago. So hospitals are finally, at least the more advanced, forward-thinking hospitals are saying, well, you know what? Employing a physician, giving them a salary and turning them loose on the marketplace probably isn't a good idea anymore. So they're doing one of two things that we're seeing at a national level. One is they are retaining the doctor through various relationships, but not necessarily employing them. You know, these are clinically integrated networks, physician hospital organizations, but any way they can bind you and me in a relationship, but you're not on my payroll. And that way they can engage, the physician has the freedom to come and go as they please with other, let's say other hospitals, but they're also participating in various health plans and participating in various projects with that hospital itself.
So in the end, which is better for the patient?
Well, I think a patient that is in a non-employed environment, obviously I have my personal biases because that physician has the freedom to pick different relationships depending on the patient needs. When a physician is encumbered by one hospital, saying, hey, I'm employed by hospital A and that hospital doesn't have specific skill sets, pick one, neurosurgery, thoracic surgery, then what do? Then you have to figure out a way to get around that and take that patient to a different environment. So what we're seeing is a lot of hospital systems who have employed doctors have said, it's too expensive for me to manage, so they hand that group of physicians off to a third party. And that third party, who's probably more adept at running a physician infrastructure, can do it at a far better cost. So those are the employed version. The physicians who want to remain independent are saying, well, we want the same thing. We want that infrastructure, but we want the freedom to engage the hospitals of our choice, the patients of our choice. We want that freedom, but we can't go out and fly solo anymore. The expectations of Medicare, the expectations of electronic medical records, I mean, the cost of maintaining a physician's infrastructure has probably tripled in the last 25 years, just on mandates and legal expectations. Human resource expectations alone have added significant administrative cost to the physician today. So everyone's seeking shelter. The question is, are you going to seek shelter as an employed physician, or are you going to seek shelter as a collaborative doctor that's looking for a large group, but have some flexibility to still be your own person?
And be independent.
Yes.
Right. Okay.
Yes.
Well, thank you very much for that insight. It's
You're very
complicated, but
It is. I always compare that with farmers' co-ops. It's just a little more complicated.
right. All right. Thank you so much. We will be right back.